Good afternoon, one and all. Myself, Dr. Rupa. I'm a consultant in obstetrics and gynecology, Hyderabad. Some students have asked me to explain regarding the management of Rh negative pregnancy. It is very long topic, so we'll discuss only the management. Okay, within 15-20 minutes we can complete only the management part. So let us be clear in that. Okay, remember more when compared to learning is important. So we'll study detailedly regarding the management. Okay, every time when anything, any Viva question or any 4 mark question, when they ask management, please split the management into investigations. Okay, investigations, how you diagnose is important, and the treatment part. Okay, see, when you say like this, now the examiner or the people who are taking Viva will feel very happy, who are correcting your papers will be very, very happy. Okay, so management will consist of investigations and treatment. The first thing is every time in the investigation, the first place is always to the history taking. Always, if you don't know anything, also in the medical part, what you'll do to the patient means one word you should say that is, I'll take the history. It is very important, that much important. Okay, your treatment and history taking are equal. Okay, and next is the antibody testing. Third is the amniosynthesis. Fourth is the ultrasound. Fifth is the Doppler waveforms. Treatment will come in the, we'll read in the next slides. Okay. Okay, next history. History taking means you'll ask the mother, the patient, any previous feto-maternal hemorrhagic conditions like miscarriage, stillbirths, or any neonatal deaths because of severe jaundice. You'll inquire all these conditions. And second point, you'll ask her whether her husband is homozygous or heterozygous. Why you should ask this? Because you all know that Rh negative pregnancy is mostly, Rh isoimmunization is mostly because of mother is negative and the father or the fetus are positive. For this condition only the isoimmunization will result. Mother will be negative, father or the fetus will be positive. Okay. In homozygous, what happens is if he is positive, there is 100% chance of fetal affection. In heterozygous, there will be only 50% chance of fetal hemolysis. Okay, only 50. And if we take any two, only one will be involved in the heterozygous condition. On homozygous, there are 100% chance of involvement. Okay, in this slide we have covered the history, the pathogenesis of Rh isoimmunization, and then the history taken homozygous or heterozygous, the husband. Next slide. Antibody testing. In antibody testing, we measure the IgG levels by indirect Coombs test. Okay, and the critical values are of antibodies are 1 is to 16 or levels greater than 10 international units per ml. Okay, now the testing is done at 12 weeks. Okay, testing done at 12 weeks. In 12 weeks, we'll see. If we do the test, sometimes it will come negative. In case of negative, the patient is priming. The patient is priming. Repeat the test at 28 and 36 weeks. If it is multi, the patient is multigravida. Repeat the test monthly from 28 weeks. Monthly from 28 weeks. If the test is positive, monitor the patient in a well-equipped hospital to prevent complications. Okay, so antibody testing is important for this purpose. So you do it at 12 weeks. Critical values are 1 is to 16, greater than 10, and primary condition, multi condition when you will measure, and if it is positive, what you'll do. These are the important points in this slide. Next, amniosynthesis. In amniosynthesis, we will observe the amount of bilirubin in the amniotic fluid by spectrophotometry. Okay, the bilirubin in the liquor is measured at an optical density of 450 nanometers. It is measured at 450 nanometers. As the amount of bilirubin shows the deviation bulge. Okay, deviation bulge. Greater the deviation bulge, greater is the fetal hemolysis. This condition is plotted on the graph, that is Lily's chart. This condition is plotted on the Lily's chart. In the whole slide, the important points are: where is the optical density of the bilirubin? 450 nanometers. What is the deviation bulge? Greater the deviation bulge, greater is the fetal hemolysis. Where the condition is plotted. Lily's chart is very important. They'll give a small clue that the following Lily's chart showed something and something like that. Then what will be the diagnosis? Why you did it? How you will manage it? What are the investigations you are done? These all the conditions will be asked in the examinations. Okay. Now in the next slide, see. I have shown you now, depending upon the amount of bilirubin, there will be a deviation bulge. More the deviation bulge, more is the fetal hemolysis. Okay. And the zone 1, zone 2, zone 3. Lily's chart. That is, in zone 1, unaffected baby or mild. Continue till term. Continue the pregnancy till term. In this condition, in zone 2, moderate condition. In this, the fetal hematocrit is less than 30. Do intrauterine transfusions. Okay. Continue the pregnancy till 34 weeks. Okay, 34 weeks. And last is a severe condition, 34 to 38. 34 to 38, depending upon the severity, you please terminate the pregnancy. And last is a severe condition in which termination of pregnancy done whenever required. Termination of pregnancy is done whenever required. So Lily's chart will be helping in knowing whether zone 1 means it is a mild condition, continue till term, no problem. Okay. In moderate zone 2, fetal hematocrit will be less, continue from 34. Up to 34 is a zone. After 34, whenever it is required, please terminate the pregnancy. In zone 3 or severe condition, by 34 weeks, give a dose of steroid and terminate the pregnancy. Okay, this is the Lilith zone and this is the management according to the chart given. Okay, next. Ultrasound. See the fetal high drops. This is a condition. In ultrasound, first we'll observe fetal high drops condition. Fetal high drops. There may be polyhydramnias, pleural effusion, pericardial effusion, there may be ascites collection. Okay, see because of the collection of the ascites, see the bulging of the abdomen of the baby. Okay, immediately after the birth, see how the baby will be. Okay, these are the ultrasound features and these are the baby features after delivery on table. Okay, next. Doppler flow velocity waveform means it is observed. These waveforms are observed in umbilical artery and middle cerebral artery. In this, we give importance to the middle cerebral artery more because middle cerebral artery helps in evaluating fetal anemia and fetal acidosis. Okay, see by Doppler we are observing all the middle cerebral artery. Now we are seeing and we see all these waveforms. Depending upon the waveforms, we evaluate the fetal anemia and the fetal acidosis. Okay, a value greater than 1.5 multiples of median. They describe it as 1.5 MOM. Indicate mild to moderate fetal anemia. Why I am discussing all those investigations, in examinations they will be asking which of the following investigations is done for fetal hydrops or all are the investigations except one. So in management we always discuss the investigations, the diagnostic part and also then the treatment part. Okay, now we all completed all the investigations. Now we will come how we will manage a patient, how we will treat a patient with RH isoimmunization. Okay, next is the treatment part. Okay, in treatment we'll see if the mother is unimmunized, that is priming, or unimmunized mother, no antibody transfer still now. Unimmunized mother, continue the pregnancy till term Okay, give her anti-D within 72 hours, dose of 300 micrograms. Okay, immediately after delivery, now you check the after delivery completed, give her anti-D or Rogen. Okay, within 72 hours, the dose is 300 micrograms. Now next is if the patient is immunized, if it is a mild condition, continue the pregnancy up to 38 weeks. If it is a moderate to severe, terminate the pregnancy from 34 to 38 weeks depending upon the condition. Depending upon the condition, terminate the pregnancy. Okay, you can induce her, means patient, with prostaglandin gel. Okay, then followed by low rupture of membranes if required. On urgency, plan cesarean section. Okay, if everything is well, patient unimmunized, primary, mild condition, just induce her with prostaglandin gel and the low rupture of membranes can be done. But if required any urgency is there, please plan for cesarean section. Next, during labor. During labor, what are the important points? First one, monitor mother vitals, continuous fetal heart rate monitoring. Okay, in stage 1, you have to monitor the vitals of the mother and continuous fetal heart rate monitoring in stage 1. Stage 2, avoid ergometrin. In second stage, okay. And next, observe for PPH. Observe and avoid PPH with other oxytocin like oxytocin, symptom or any other thing, but avoid methargine in case of RH isoimmunization because it causes the feto-maternal hemorrhage. It causes mixing of the mother's and the fetal blood. So please avoid the ergometrin. Okay. And in case of cesarean section, avoid spillage of fluid into the peritoneal cavity. Okay. These are the important things you should take care during delivery. Okay. Next. Now, after delivery is completed, I have said that Rogen or anti-D within 72 hours you should give dose of 300 micrograms. In case of miscarriage, ectopic, hydatidiformol, dose of 100 micrograms should be given. Okay, 100 micrograms should be given. If now we all completed the delivery, the care you should be taken, the dose should be given, that's all, it is completed. Now what you'll do is, if any Fetal intrauterine transfusions are required. Transfusions are required. That is, if fetal hematocrit is less than 30%, then we'll give the intrauterine transfusions. In that, we'll give the intraperitoneal and umbilical transfusion can be given. Okay, intravascular. Intravascular transfusion. Intraperitoneal means this RBC are transfused and taken up by the diaphragmatic lymphatics. Okay. In case of intravascular, through umbilical vein. Okay. What you have to transfer? O negative blood compatible to mother and fetus. Both. It should be compatible to mother and fetus. Intraperitoneal and intravascular transfusions can be done. Now the last is, if required, exchange transfusions are done on some criteria. Why I am focusing on this is so many multiple choice questions are given based on this criteria. If you take last 10 to 15 years question papers, almost this question will be repeated 3-4 times. 4-5 times also you can take it. That much important in all the examination like GIPMAR, AIMS or any NEET PG or if you take for FMG students, exchange transfusions criteria. What is the criteria? First one, when you will do the exchange transfusion to the newborn, means first one, when the hemoglobin level is 11 less than 11 grams per deciliter or cord blood bilirubin greater than 4 milligrams per deciliter, total bilirubin level greater than 20 milligram per deciliter. Last one, in spite of phototherapy also, in spite of phototherapy also, the rate of bilirubin increase as 1 milligram per deciliter per hour. Even when you are giving treatment also the bilirubin level goes on increasing. At that time we can plan for exchange transfusions. Okay. As I thought that the class should be very short and sweet, I have collected all the important information what the undergraduate and a student preparing for the examinations, competitive examination should know. Those points I have collected and I have presented here. Okay. I think these are sufficient to the knowledge extent at present. Okay. And I would like to end the session here and meet you all with the next topic. And if you all want to give any feedback or any suggestions, you are almost welcome. Okay. And if you want any other topics to be explained, what are the most MCQs, those points will be stressed more. Okay. Please give me all your feedback and let's meet in the next class. Thank you.